2, routine versus major medical treatment under the New York State Family Healthcare Decision Act. This morning, we'll be using a cardiac case illustration. I am Dr. Renee McLeod-Sordjan, an ethicist and nurse practitioner. The Family Healthcare Decision Act is a New York State law that's enacted to help patients without capacity have a surrogate. These patients would not have established a healthcare proxy, and the Family Healthcare Decision Act provides standards for that decision making. Routine versus major medical treatment is sometimes a case of conflict. Routine medical treatment are basic diagnostic treatments, such as medications, blood draws. They don't usually require specific consent. Think about things that are short-term that we do. For example, post-operative ventilator use, expected to last for less than 1 month, usually less than hours or days. These can be authorized directly by the attending practitioner, which under New York State law is a licensed independent practitioner, physician assistant, nurse practitioner, or physician. Generally, routine major medical treatments are low-risk, everyday interventions versus major medical treatment, which is expected to require significant risks. For example, surgery itself, general anesthesia, or anything that invades bodily integrity. This requires independent concurrent determination that there is a need for that major medical treatment. Think about admissions to hospitals where we require going to an intensive care unit, which requires the ER practitioner and the ICU consultation. This includes the use of restraints, even non-emergently, and use of psychoactive medications that are expected to extend beyond 48 hours. These decisions are made after consultation with concurring determination and record keeping. These are considered high risk, prolonged treatments that require extensive oversight. Cardiopulmonary resuscitation, or CPR, under New York State law are measures that are required to restore cardiac function or support ventilation during cardiac or respiratory arrest. These are presumed to be life-sustaining treatments that without such, there would be death. CPR under New York State law does not include measures to improve ventilation or cardiac function in the absence of respiratory or cardiac arrest. Think of ECMO. Think of intubation that occurs to improve asthma function prior to respiratory arrest. So we are going to present a case scenario. This is a middle-aged patient who's been placed on extracardiopulmonary mechanical oxygenation and an intra-aortic balloon pump. They have no healthcare proxy and no advance directives. Remember, if a healthcare proxy exists or a MOLS form exists, the Family Healthcare Determination Act would not be the case. The initial situation is that critical care interventions have been started. So let's think about what interventions can be considered emergent or implied that do not require a surrogate consent. If you've thought about that, a patient who suffers a cardiac arrest who doesn't have a surrogate immediately available, CPR and resuscitation is implied, unless a medical order of life-sustaining treatment exists in New York State or any other state form, such as a PULSE form, physician orders of life-sustaining treatment. The emergency initiation of ECMO or IABP can be justified as emergent care. Once stabilized, though, the patient's further decisions, including the withdrawal, may require surrogate consent. Well, in emergencies, care can proceed without surrogate consent. Under the Family Healthcare Decision Act and other laws, existing law on implied consent applies in emergencies. Physicians may provide life-sustaining interventions such as CPR, ECMO immediately if that delay would risk death or cause serious harm. In other words, there's no need to wait for surrogate identification when rapid action is required and no pre-existing MOLST DNR exists. Let's return to this case. Now they've been placed on ECMO, as well as having no healthcare proxies. What interventions can be adjusted or discontinued as routine medical treatment versus what requires surrogate consent? In other words, we're immediately after the emergency. In the continuation or thinking about this case, what is routine and what is not? Well, routine care is adjusting the medications for blood pressure, sedation, use of pressors, removing or weaning pressors when they're not beneficial, removing or weaning medications when they're not beneficial, imaging, antibiotics, chest x-rays, labs. Those do not require surrogate consent. In other words, physician and clinician medical opinion, medical plan of care can be started or adjusted or stopped by the attending practitioner as part of routine clinical judgment. So, what is major medical treatment in these cases? These are defined as involving significant risk or prolonged burden. We can think about the initiation of ECMO or IABP as high-risk invasive procedures in the absence of emergency, hemodialysis, the decisions to continue or discontinue that long-term ventilator. These require surrogate consent. And in some cases, when there is conflict, an ethics review committee, or perhaps even involving legal and court-ordered treatment. As this case continues, the patient then does suffer cardiac arrest, and the condition is considered terminal, such that continuing any other treatment will not restore the person to their prior function. At this point, ECMO, IABP, CPR are considered life-sustaining treatments. Withholding or withdrawing these interventions now must meet the standard of the Family Healthcare Decision Act. And that standard is that there is extraordinary prolonged suffering, such as would be deemed inhumane, or that the person is terminal or permanently unconscious. The surrogate is required for withdrawal unless the patient has prior directives, and in cases where those surrogates have discord or conflict, may require ethics review consultation or court. And so, in summary, routine medical treatments do not require the surrogates, adjusting the medications, the labs, or minor procedures. When it has become a life-sustaining treatment, withdrawal requires surrogate consultation or may trigger ethics involvement if there's dissent or conflict under the Family Healthcare Decision Act. Major medical treatment, such that involves the integrity of the patient or the integrity of their body, requires surrogate consent with concurring determination by another practitioner. And let's remember, the Family Healthcare Decision Act and everything that we talked about is when the patient lacks capacity to make the medical decision themselves and has not left the healthcare proxy. Let's also remember decisions that the patient made when they had capacity or binding, and the surrogate should make those decisions according to the patient's substituted judgment. And when the patient's substituted judgment does not exist, it's in the best interest of the patient, as the patient would have made those decisions themselves. And I thank you for joining me for this 10 minutes of discussion. These slides may be used for permission with written permission by myself by the email below, and please use the citation. Thank you very much. This is Renee McLeod-Sordjan.